it will be too formal to thank Dr. Manoj and Purvi. They are too close to me for a very long period of time. I'm going to speak about relatively newer introduction in the field of kidney disease and heart failure of late, which is Finrenone, belongs to the class of mineral corticoid receptor antagonist. So this is the line through which I will be presenting. We know that cardiorenal protection is extremely important and early diagnosis and intervention is very important. There is a huge burden of cardiovascular disease in type 2 diabetes, and there is a huge burden of chronic kidney disease also in type 2 diabetes. But let's not forget that when we talk of cardiovascular disease, there could be an inherent kidney feature and vice versa. In a CKD, you could probably have some amount of cardiovascular disease as well. So that's something which we have to keep in mind. Very importantly, if we compare the healthy individuals against those who have a chronic kidney disease or diabetes or both together, then they could be respectively losing, you can say 5.7, 10.2, or even 14.8 years of life as far as gentlemen are concerned. And for ladies with chronic kidney disease and diabetes, they could lose more than 16 years of their life. So that's something which is to be kept in mind. Now, assessment of albuminuria, though not going in details, but it has been written in the guidelines for a very long period of time, and we should be doing it at least once in a year. Not one reading, but maybe sustained. So one reading today, one reading after around 4 weeks, and one reading another 8 to 12 weeks. So sustained albuminuria is something which is called as albuminuria, urine albumin creatinine ratio. Early detection of kidney problems is certainly possible with detection of albuminuria, and you can do it right in your clinic also. And then calculation of the estimated glomerular filtration rate, GFR, less than 60 technically defines chronic kidney disease. It's very important to keep in mind that we always discuss chronic kidney disease from the point of view of albuminuria and eGFR, but it is also a very important inflammatory disease. The recent issue of American Journal of Kidney Disease talks of 2-3 important things. One, they insist on reducing the albuminuria cutoff. Normally, we say that more than 30 milligrams per gram creat is abnormal. They say that bring it down to somewhere around 10. Point number 2, they insist that albuminuria is foreteller of lots of problems, endothelial leakiness, capillary dysfunction, and that's why probably coronary artery disease as well. And another important thing, the inflammation, chronic inflammation related kidney disease, that is something which carries the risk of some more problems like maybe gout and different arthritis, the COPD, different kinds of infections like pneumonias. And mind you, there are small studies with Finrenone. They have shown that yes, these inflammatory and infective problems also can be reduced. The risk of these problems is actually higher than the risk of cardiovascular disease in chronic kidney disease. This is just an example. A gentleman with an eGFR of 62 and appears to have a low risk of CKD progression because he is not at less than 60. However, if we also do his albuminuria, then he fits into what is category called as A3, which is certainly a very high risk of progression to further stages of CKD. So both CKD parameters, UACR as well as eGFR, both of them need to be considered when we define and decide the treatment. Very important, on the time axis, if we see, albuminuria is something which gradually going to creep up. GFR is something which is gradually going to come down. And along with albuminuria, kidney fibrosis. Unfortunately, we don't measure kidney fibrosis in the clinic, but that's something which is the real villain. It is actually reducing the kidney reserve, it is reducing the nephrons. So that is the point which we have to certainly take in point. And Finrenone is a drug which certainly is going to address that kidney fibrosis. Increasing UACR is a factor of CV death, as I told you. And I told you that the nephrologist, at least, they say that not 30, but the cutoff should be less than 10 to actually risk stratify the kidney people from the overall mortality, all-cause mortality as well as cardiovascular mortality point of view. Guidelines recommend both eGFR as well as estimation of UACR at least once in a year. All the guidelines, ADA, KDIGO, ACE, Our own RSCDI guidelines also, they insist on the same. Now, what are the drivers of CVD and CKD progression which are being addressed? So, the important point here is there are some, you can say, factors, generalized factor or systemic, like for example, increased oxidant strain or increased inflammation. They can, in their own right, certainly stimulate the mineralocorticoid receptors. Actually, that over stimulation of mineralocorticoid receptors is something which is going to be a problem. Otherwise, in a physiological state, they look after the water and salt balance. Now, mineralocorticoid receptors are expressed in the kidney substance. They are expressed in the heart and the vasculature, even in the CNS. Importantly, they are distributed in the adipocytes also. So, for a diabetic patient, the aldosterone, which is actually the main trigger of MR stimulation, that may not come from the adrenal gland, but it can come through the inflammation, it can come through other sources like maybe the adipocytes themselves. So, aldosterone and cortisol are the important stimulators of MR overactivation. Now, why does cortisol? It doesn't really give you MR overactivation in a general sense, because there is a thing called as 11 beta HSD. This is an enzyme which is there in the kidney substance especially, and that actually breaks down the cortisone to other metabolites so that they can't get attached to the mineralocorticoid receptor. That's how the things are saved. However, the aldosterone excess is a feature, RAS overactivation is a feature of diabetes. Oxidative stress, high albuminuria itself can trigger mineralocorticoid receptor overactivity. That sets lots of things. For example, hemodynamic aspects, inflammatory and fibrosis aspects, and metabolic aspects. We know that hemodynamic aspects in the kidney issue, it is handled by the RAS blockers, to some extent by the other antihypertensives like maybe CCBs, and even the glycologins, SGLT2 inhibitors, can give you some amount of systolic diastolic BP advantage. Metabolic, of course, is handled by the different anti-diabetic molecules, specifically the SGLT2 inhibitors, which we are talking through and through this conference. But inflammation and fibrosis is a neglected area, and the new molecule Finrenone addresses that. So, tubular interstitial damage in inflammation, glomerular sclerosis, mesangial expansion, glomerular hypertrophy, and then at the same time, don't forget heart. In the heart, simultaneously, there is an element of myocardial fibrosis, atherosclerosis, vascular stiffness. They call, the AZKD people call this as a inflammaging, right? So that's something which we have to keep important. Now, of course, the left ventricular hypertrophy. So Finrenone is one which is going to address the mineralocorticoid receptor overactivation. It is a different molecule compared to the spironolactone or eplerenone in more senses than one. Number one, the spironolactone and eplerenone, they will actually concern about only majority on the, you can say, specific aspects of the story as far as the MR receptor is concerned. If there is aldosterone, they will be active. If there is no aldosterone, or there are other stimulators of MR overactivation as I have just described, then they just become less efficient. Whereas Finrenone is something which is called as an inverse agonist. So it actually blocks the recruitment and binding of the transcriptional cofactors as well. So it's a wholesome mineralocorticoid receptor blocker or antagonist. So it not only, you can say, gives you an advantage of improving hemodynamic factors, inflammation, fibrosis, and albuminuria, but it slows down the chronic kidney disease progression in the true sense of the word. Oh, these are the differences between the different mineralocorticoid receptor antagonists, spironolactone in market or in use for more than half a century, eplerenone for practically 2 decades, and Finrenone over the last few years. So the important point to be appreciated here is spironolactone certainly useful for congestive heart failure, used in resistant hypertension, same about eplerenone, but the risk of hyperkalemia is very, very relevant, very, very important, to the tune that you can't use high doses of these drugs and you have to be very, very watchful whenever you are using these drugs for whatever indication. The reason is they have predominant effects on the, you can say, specified aspects. The distribution of these is more in the kidney, whereas for Finrenone, it is equal distribution between heart as well as kidney. Other important thing, the half-life of Finrenone is comparatively lesser than spironolactone or eplerenone, so that gives a relatively lesser risk of hyperkalemia. So that's something which we have to really keep in mind when we use these drugs. So when we talk of holistic treatment of chronic kidney disease, naturally RAS blockers are on board for a very long period of time since our student days. They affect the efferent arterial tone, they reduce the intraglomerular pressure, hyperfiltration is controlled, endothelial dysfunction, cardiac remodel is certainly modulated. Gliflozins, I will not again go through all the things, but they are certainly proved to be very nephroprotective, and potentially the GLP analogs could also, they reduce albuminuria. Whether they really prolong the EGFR decline, that's something which is yet to be proved. But Finrenone certainly decreases inflammation, fibrosis, endothelial dysfunction, and very importantly, tissue modeling and proteinuria. All the others, the precursors, I would say, RAS blockers or gliflozins, they have in their different illustrious trials, they have certainly shown that they reduce the risk, but there is certainly a residual risk remaining. We have lots of trials of Finrenone, and the famous ones I am showing, the Figaro DKD and the Fidelio DKD respectively. Fidelio DKD looking more at the kidney problems, and Figaro DKD looking chiefly at the cardiovascular endpoints. So this is a large pool. Together they are called in a analysis, they are called as a fidelity analysis. 40% of the patients had albuminuric CKD with preserved kidney function, and there were shades of albuminuria through the pooled analysis. Very importantly, the fidelity outcome has shown that the composite of cardiovascular, there was a 14% relative risk reduction, hospitalization for heart failure, 22% relative risk reduction, kidney endpoint, 23% relative risk reduction, and dialysis, the need of dialysis, relative risk reduction, 20%. All statistically very important. Heart failure, if we look at, there was a reduced risk of heart failure hospitalization, 22% in the fidelity analysis, 32% relative risk reduction in the risk of new onset heart failure in the Figaro DKD analysis. And thereby, the European Society Cardiology, they have given, they said that in patients with CKD and type 2 diabetes, recommended reduce the risk of heart failure hospitalization. Finrenone is being given a grade of class 1A. Finrenone reduces the UACR, as we have already seen, compared to the placebo. Very important. Fidelity gliflozin group, if they were on SGLT2 inhibitors, they shown a better albuminuria reduction compared to a monotherapy of Finrenone. And that has actually taken the things further, which we'll immediately discuss. Finrenone had similar adverse events compared to placebo, not very significant. Risk of hyperkalemia, but not to the tune that patients have to discontinue drug for all the time. Confidence is a trial which investigated simultaneous use of Finrenone and SGLT2 inhibitor in chronic kidney disease and diabetic patients. Different shades of EGFR, A1C, and hypertension, ASCVD as comorbidities. You can see that there was with the simultaneous initiation of Finrenone and SGLT2 inhibitor, the UACR reduction was more prominent, up to 52%, and consistent albuminuria reduction. Most of the patient, in fact, more than 30% reduction in UACR is recommended by ADA, and 70% of the patient who use Finrenone and gliflozin together, they achieved that parameter. Importantly, the initial systolic BP decline and the initial EGFR decline was actually reversible after the drugs were stopped at the end of 180 days. Again, serum potassium elevation, actually speaking, it was lesser. Hyperkalemia risk was relatively lesser if the patient was on Finrenone plus a gliflozin rather than on Finrenone alone. So this is the confidence trial summary. Early reduction in UACR with a dual use of this. 70% patients achieved ADA, recommended more than 30% UACR reduction, and adverse events were absolutely acceptable. Just couple of minutes. The Finrenone is US FDA approved, and it has been approved in the patients for type 2 diabetes to reduce the risk of sustained EGFR decline, ESKD, CV death, non-fatal MI, as well as hospitalization for heart failure. Various societies have certainly held Finrenone in a good respect, and this is something which has been now a pillar. So RAS blockers, mineralocorticoid receptor antagonists, and gliflozins, they are the pillars of management of CKD in type 2 diabetic patients. And if you really use these drugs together, then you can see that on variables like heart failure, hospitalization, all-cause death, kidney failure, or composite of CKD, there is a improvement in the lifespan
Dr. Subhash,
by
can we
sizable number
limit
of
our...
years. Thank you so much for kind attention, all my friends. Thank you so much.
Thank you so much.